Welcome back to the Oncology Journal Club podcast, your essential dose of the latest oncology research, expert analysis, and our trademark blend of healthy skepticism and bad jokes. I'm your producer, Rachel Babin, and I'm once again joined by our Journal Club dream team. Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. This week, Kate kicks us off with her report from the ESMO GI meeting with lots of key highlights. Craig sparks a fascinating discussion about robotic surgery. Just a quick word of warning, this chat does include some strong language. CJ takes up a listener's suggestion and talks us through the atomic study. And of course, we've also got our regular PBS updates and blow your own trumpet papers. If you'd like more information about the Oncology Network, including a transcript of this episode and links to the papers, head over to oncologynetwork.com.au. Thanks for tuning in. Let's get started.
G'day. Welcome to Series 3, Episode 7 of the OJC podcast. Welcome to Dr. Kate Clarke.
Hola.
Spanish.
Spanish. Oh, I've come back from ESMO GI, which is a really good excuse to go to Spain. So,
yeah, great. So you learned a word. Good on. Well done. And Professor Jackson.
Kia ora. I'm really good. I've not been to Spain, though. It sounds quite good. Barcelona.
Kate, now we're winging our way to Barcelona or Madrid?
Barcelona. That was hot enough, thanks. I understand Madrid went over 40 while I was away, but 35 will do me.
And you went to ESMO GI.
ESMO. It's an odd meeting. It's a combination of data, meeting the experts and educational sessions by the sea in Barcelona and right next door to Marbella in the area nudista. So lunchtime is interesting. I want to start with actually quite a brief abstract.
I didn't follow that. Why was lunch interesting apart from the fact that you're in Spain?
Translate.
She said the nudista.
Area nudista. No?
No.
Your Spanish needs brushing up before you go to the nude beaches in Barcelona, Craig.
Oh. Sausage on the menu.
Oh, come on, Craig. There was more sausages than at a regular Barbie. Yeah.
Okay, got it now. Anyway, can you want to tell us about the interesting abstracts?
So this is an interesting abstract, but very niche, right? So for context, in Aotearoa, New Zealand, there is a very extended now whānau who have a preponderance for germline CDH1 pathogenic variants. Sadly, they have very high penetrance for diffuse gastric cancer. And at the moment, recommendation is for gastrectomy at relatively young age, so in the mid-20s. The feeling has always been in New Zealand that surveillance is not adequate and cannot adequately replace gastrectomy. There are multiple now families all over the world who have been diagnosed with germline CDH1 pathogenic variants, and the Spanish have published their experience of a grand total of 70-something patients, I think. And they looked at 78 groups. They looked at 3 groups. Group A, the patients who had their CDH1 diagnosis and chose to have a prophylactic gastrectomy, average in their 40s. Group B, who had a CDH1 diagnosis and declined gastrectomy, but continued to have surveillance. And Group C, those patients who only had their CDH1 mutation diagnosed after they had a clinical diagnosis of gastric cancer. Group C, so those patients with a post hoc diagnosis CDH1, do appallingly badly, and their median survival is in the months. Group A and B have identical long-term survivals and live a normal lifespan. My nervousness is that this was presented as CDH1 germline mutation carriers probably don't need gastrectomy. So I'm desperate to connect with New Zealand very extensive CDH1 mutation diffuse gastric cancer network to say, could they please publish their data and head over to ESMO GI and present it so that we don't get stuck both with patient education, thinking that this isn't necessary in our population, And that, more importantly, the regulators don't say, why are we doing a very expensive operation that's not necessary? Because this is not our experience in New Zealand. These people get their gastric cancers very young if they do not become unwell as a result. The Spanish community seem to only get a series of T1A tumours throughout their stomach, and if you sit on top of them, they actually don't become anything worse. It's a little bit like a sort of a DCIS situation, which is fascinating. So that was my little very, very niche last abstract on the Saturday morning, but I was like, oh, crap.
You're in luck, Kate. This ESMO GI in 2026 is in Munich, so there's probably going to be more sausages for lunch. So, Chris, were you going to say something intelligent?
Yeah, well, look, I think the CDH1 group, obviously, Professor Perry Guilford from New Zealand was the chap who sequenced CDH1 in the first instance. So it is an issue which is very close to the hearts of many Kiwis in the oncology field. Talking with Perry in the past, he was saying it's becoming increasingly difficult to get the youngsters in that whānau actually into gastrectomies because they haven't had the experience of losing someone with cancer before. So many of them are actually either opting for surveillance or for disengagement with therapy overall. So the success of the prophylactic gastrectomy has had a perverse outcome of actually disincentivizing people from intensive surveillance and follow-up.
Yeah, which makes me very nervous. So I wanted to have a chat with Perry and those associated with Perry and see if we could collect some more data. And, we know that there are several whānau who are very well connected and collect their own prospective databases. So my colleague, Professor Patterson, Associate Professor Patterson, and I will be working on that in the near future. So that was something I was very excited about.
Good. Kate, anything else caught your attention there?
Yeah, look, only because, parochially as I am, Associate Professor Andrew Dean from AGITG, where's our trumpet? Presented the phase 2 study of sertepeptide when added to gemcitabine and nab-paclitaxel in patients with untreated metastatic pancreatic ductal adenocarcinoma, and there is a progression-free survival benefit that is significant. Now, Chris, you're mentioned as one of the co-authors on this study.
Oh, shucks, Kate, shucks.
We have got 6-month PFS for the CERT arm at 60.8%, and for just the nab-paclitaxel at 25%. So that feels pretty stonking for me. Median progression-free survival of 7.5 months versus 4.7 months. So that's pretty exciting.
So tell us about the intervention.
So it's another one of these trying to get into the pancreatic cancer. So, we've seen this before. Hyaluronidase looked great in phase 1 and 2 and didn't work out in phase 3. So I have my fingers crossed for this one. And so the idea is that it helps get the cancer drugs through the tumor microenvironment and into the cancer. Chris, you obviously were involved in a trial. Any experience of giving or knowing which one you were giving? Any guesses as to toxicity?
Well, the very first study that was done with sertepeptide had some stonkingly good responses, so we're all pretty excited on the basis of the response rate from the initial smaller study, and so there was a lot of excitement around this. I think, just to clarify, there were 2 cohorts. One was a single dose of cert, the second was 2 doses of the sertepeptide, and the 2 doses of sertepeptide had a better PFS and response rate as well. So the dosing does seem to be important in terms of getting the drug in over a period of time, and contextualizing it against the impact study, so Gemabraxane registration study, just to see how it plays out, because this was a non-randomized and everyone got the drug right. The overall response rate in the impact study was about 23%, and it's 45% in the cohort B. Median PFS in the pivotal study 5.5 months, and it's 7.5 months in this. Median overall survival 8.5 months, and not yet fully matured in this cohort too. So it's adding 2 or 3 months onto Gemabraxane without actually much in the way of additional toxicity. We put maybe half a dozen or 10 patients onto the study, and really nothing in terms of additional toxicity. It was pretty well managed. Lots of paper toxicity, Kate, in terms of lab abnormalities, but nothing that really made a big difference to patients' quality of life. So toxicity was manageable. No unexpected signals.
Yeah, good. I know that you have to collect the neutrophil count of 0.9 and the hemoglobin of 101, but it frustrates the crap out of me. But there was one really good session at ESMO GI. I'll just divert for a second, where they presented all of the quality of life data from a whole series of big trials and produced them. So Matterhorn I can't sit here and remember them all, but it was all within CUI of presenting the data, the OS and the PFS. And rather than now talking about time to deterioration of quality of life, the investigators are trying to make sure that, particularly when we're treating patients palliatively, that we're improving their quality of life as a goal, which I think is really, really exciting.
That sounds like a common sense principle.
Yeah,
Kate.
and much more useful than writing down every time somebody gets a lymphocyte count of 0.3, which is what we're doing at the moment. So, yes, I think that was really helpful.
So just back to Ascend for a second, then we're going to move on. Where to next for this molecule?
Yeah, survival data will be really important to get out for this. I imagine that the company was AGITG-led study, right? So again, not a pharmaceutical study, but I would imagine if the study's positive that the company would look to try and get registration from it. But it's still, it's still smallish study, Craig? Still not that big.
That's right. All right. Kate, anything else?
Yeah, look, I want to recommend everybody to see if they can get hold of Vinod Balachandran's presentation at ESMO GI in the immunotherapy session on RNA vaccines for pancreatic cancer. Dr. Balachandran is a surgeon who is now the director of the Allianz Centre for Cancer Vaccines, and it was an elegant presentation about the work that I think I have spoken about several times before, working through the justification for what he's doing, the understanding that those 10% of patients that do well with resected pancreatic cancer, it's probably because they have the ability to develop their own long-term, long-surviving anti-T cells to neoantigens, and then figuring out how to get more and more patients to do that. In his very small trials that are very complicated, they're at about 50% of patients being able to create those long-term T cells clones, and they do have significantly longer disease-free survivals. The very interesting, very simple thing he said was if you take someone's spleen out, they don't do well. Now, of course, that's something that's routine part of a lot of people's pancreatic cancer surgery. I just thought this was incredible. It was laid out beautifully, the justification for it, the very basic science, and listening to someone who knows their shit backwards is always really illuminating because you walk away understanding it rather than going, what just happened? So it was great.
Fantastic.
The splenectomy data is fascinating. The same is actually true in colon cancer. There's some single institution studies which show that if you take the spleen out in hemicolectomies, they do a lot worse in terms of DFS data. And so it must be a similar immunoregulatory mechanism there as well.
Yeah. The other theory that came out is that actually the reason why FOLFIRINOX helps is that you've got in that micrometastatic population, you're all of a sudden you're doing some immune modulation, but you're also making more neoantigens available to the immune system when it matters. And so you're providing a few more patients to have that ability to make more long-term T cells, which is not how we thought these things worked, but it was an interesting mechanism.
Well, that's really interesting. So, Kate, what we'll do is we'll try and find a link to that presentation and put it in the meeting notes.
Yeah.
So I chose something as a long paper, but I'm going to whiz through it a bit. It was a paper about robotic surgery. And so this was the real randomized clinical trial published in JAMA, Robotic versus Laparoscopic Surgery for Middle and Low Rectal Cancer. The main endpoint in the study was looking at 3-year loco-regional recurrence rate. And the high-end results were, this was 1.6% for robotic surgery and 4% for laparoscopic surgery. So this was a multi-center study done in China, 11 high-volume centers in 8 provinces between 2016, 2020. 1,700 patients were eligible, 1,200 were randomized, followed up until the end of 2023. And this was using the Da Vinci robots. Surgeons had to have done a minimum number of cases, for quality assurance. So that, as I said, the main endpoint was in this 3-year loco-regional survival and significant difference. So there was an accompanying editorial, and it felt that it was time to shift towards robotic surgery for rectal cancer. Previous studies had shown an equivalence, but now this is probably the first study suggesting superiority. But before Chris jumps in and squawks about equity, the editorial did point out that the challenge is going to be how we can steward the resources at hand to optimize outcomes for patients. If robotic surgery is going to start being considered standard of care, then how are we going to actually roll this out in a equitable way? And that's a real challenge, even for high income countries.
Craig, isn't that about the first study ever that's shown an advantage for robotic surgery in anything?
Yeah, so the editorial went through that. Most of the studies in the past had shown some equivalence. Certainly, laparoscopic surgery been shown to be better than open in terms of several endpoints.
Well, in terms of like blood loss, and not oncologically superior in terms of laparoscopic versus open for rectal cancer surgery. So, I mean, that's been one of the big problems with the laparoscopic surgical movement, is that it hasn't actually shown oncologic superiority.
In terms of differences between robotic and laparoscopic, the previous systematic reviews and meta-analysis had not shown clear difference. This is the one and only study that had shown a difference.
Yeah, I mean, I think robots are highly intensive, and as I say, it's probably the first study ever to show any advantage for robotic surgery in any area except for, driving recruitment to private practices.
Yeah.
I'm very sceptical of robotic surgery as a venture in general.
We're getting our local control down to 1%, right? Do we really need radiotherapy in rectal cancer anymore?
Hang on. Maybe we should have radiotherapy instead of robots. I reckon radiotherapy is still cheaper than robots.
Oh, yeah, but radiotherapy fucks vaginas. That's the problem. So I think I'd rather have a robot in my pelvis than a radioactive source, thanks.
Yeah.
Really?
In that data that Craig presented, sexual function's much better with the robots. Only both women and men. So not with the robots, after the robots.
I mean, the thing is that two of the randomized trials in laparoscopic showed, one of them, the a la carte, didn't show that laparoscopic was equivalent. It didn't meet non-inferiority, right? So that was the a la carte one.
Yep.
There was another one where numerically the laparoscopic findings were worse than the open. Sorry, the laparoscopic were worse than the open. And it was a third study, the big one, that really is what drove the meta-analyses to say that they were equivalent. But I'm not convinced that higher tech surgery is always better.
Though I think they're quite different techs, robotic and laparoscopic, because the whole idea is that robotic's supposed to get over some of the limitations of laparoscopic, particularly in a male pelvis, which of course is the only one we care about. But yeah,
Male pelvises are more difficult for robots, aren't they? I thought.
They're much more difficult for laparoscopic, but you can get over that because you can go slower and smaller, so you can get in there with your tiny little, rather than having to. Yeah.
Oh, look, there's an advantage for men. I'm all for it.
Yes.
Still recording. Look out.
I was being provocative there. I do think it's a real issue for training as well, though, and for global surgical oncology in general around this two-tier access to robotics. And I'm not convinced that it's necessarily all that much better.
There you are. So anyway, we'll just leave that out there. I thought it was an interesting paper for people to be aware of. I hope everyone enjoyed our two-part special series on ASCO and learnt lots. I think we learnt lots. I think, Professor Jackson, you had one of our listeners reached out and said we should have presented one of the other abstracts, and I think you're going to cover that now.
Yeah, we had a long-time listener, not first-time caller, who shared some feedback with us that we should have covered the atomic study, which was in the plenary session, and I'm delighted to cover that now. It was certainly on my list of things to discuss. So the atomic abstract was a randomized phase 3 study of patients with stage 3 colon cancer who had deficient mismatch repair expression. I think most oncologists will be pretty aware that mismatch repair fixes GC base pair incongruencies, particularly which happen at the nucleotide expansion points, trinucleotide repeat sequences. And if there are errors there, it either fixes them or it kills the replication process. And cells that don't have that have hypermutated phenotypes, which is uniquely suited for immunotherapy. So lots of antigenic presentation and hopefully a great target for immune therapy. We know it works really well in the advanced disease setting, with 60% of patients getting a long-term controlled response with monotherapy and 80% with combination therapy. And so, of course, we want to bring it back into the adjuvant setting. It's a little tricky because in the adjuvant setting, deficient mismatch repair colon cancer has a better prognosis than proficient mismatch repair colorectal cancer, except for the T4N2s. So what did this study do? This was the atomic study, not yet published in the New England Journal of Medicine, but I'm sure it can't be too far away. This was adding atezolizumab to standard adjuvant modified FOLFOX6, and the headline finding was that the risk of recurrence was halved with a hazard ratio of 0.5 in patients with stage 3 DMMR. The DFS went from 76.6% to 86.6%, so a 10% improvement in disease-free survival. Is DFS the ideal endpoint in immune therapy studies? Maybe not, but you can salvage so well. We do want to see the OS data, but DFS has until now been a good surrogate. And this was clearly a good improvement in disease-free survival. What's new here? Well, dMMR tumours already respond well to chemo and even better to immune therapy in the metastatic and neoadjuvant setting, but until now we had no data showing that adding a checkpoint inhibitor to standard chemo improved survival in resected stage 3 dMMR colon cancer. And this trial delivers that data, which is clearly positive, strong p-value, and consistent with benefit across age and risk groups. The toxicity is pretty much what you'd expect from the addition of a PD-L1 monoclonal antibody in this population. I want to contextualize that a little bit with other recent studies which have gone on in the adjuvant setting and just talk about why, what the gaps are and where this is.
You're not a professor who's about to do a cross-trial comparison, are you?
No, I'm about to contextualize. Contextualization and integration and interpretation. It's not a cross-trial comparison. I was about to say that the IDEA collaboration taught us that low-risk colon cancer, T3N1, could get just 3 months of chemo. Some would argue it showed it for the entire cohort. So 3 months of chemotherapy, CAPOX, was sufficient for those adjuvant patients. And of course, the Atomic study used the full 6 months of chemotherapy, which we know has got a 30% excess toxicity of neurotoxicity with that duration. So that's one problem. In Atomic, half of all the patients would have been that IDEA collaboration duration, so T3N1. So a lot of patients potentially got over-treated. And then they got a year of atezolizumab in total. So are we over-treating this low-risk group with prolonged chemotherapy and immunotherapy? Additionally, increasingly, many centres are doing MMR on the colonic biopsy at the time of diagnostic colonoscopy. And then we have the NICHE 2 study, which, for those who remember a previous episode of the OJC, was pre-op dual checkpoint blockade of 2 doses of Nivo and a single dose of low-dose Ipi in stage 2 and 3 patients with dMMR colon cancer. And that found a 99% major pathologic response and about a 90-odd% CR rate in that population. And that was in the primary population. So if you have a dMMR patient on colonoscopy, you could ask yourself, should I treat them with preoperative 2 doses of IO, 2 Nivo, 1 Ipi, or resect and then give them 6 months FOLFOX and a year of atezolizumab? I would argue that the 2 doses of IO is a lower treatment burden than 6 months FOLFOX with a year of atezolizumab. However, NICHE 2, much, much smaller study than the Atomic study. So I reckon we'll probably see a head-to-head of 2 doses of Nivo, 1 dose of Ipi versus post-op chemo with IO to see which one comes out the better.
Do you think someone's going to randomise to those groups? The DFS now in a extended cohort of Chalabi's study is 100% at 3 years. So I would find that very tricky to randomise to.
So you've got a large randomised phase 3 and you've got a small single-arm phase 2. One has clearly got better outcomes, but it's not a randomised phase 3. And the other has supplanted the standard, which is chemotherapy in the adjuvant setting.
But, if we're going to compare this regimen, do you really think people are going to go with 6 months of chemo, 12 months of atezolizumab as the comparator in that trial? And where we know in every other disease type, neoadjuvant is better than adjuvant, I just can't see somebody doing that as a randomized trial.
So you think that the data is sufficient to recommend neoadjuvant chemotherapy off the basis of a small single-arm phase 2?
I think we're getting to where, for immunotherapy, I would happily give NICHE 2 to people, and I happily have given NICHE 2 to people. I really struggle with the concept of this Atomic trial. It's missing 2 arms. Yeah. This is it should actually have had a nothing at all arm and an atezo alone arm, if we're going to argue that 12 months of atezo is a standard. So it's got so many holes in it. I don't think this can be it's not logical the way that they've designed this trial. They've done what we always do in oncology, which is just throw more shit at people. And I don't think that's the right way to be looking after people. And I think we really have inexperience of using IO with chemo. We keep saying there's no new toxicity signals. It's a different beast to giving IO to elderly melanoma patients. Giving chemo and IO to young people who are hopefully going to live another 60, 70 years. I just think the 12 months of atezo, it just stresses me out. It stresses me out big time. Alongside the FOLFOX with the oxaliplatin and all the rest of it, it stresses me out.
Oh, yeah, look, I think you can argue that the ideal trial was not done, but I guess our job is to deal with the evidence that we have. And the evidence that we have is a large randomized phase 3 of adjuvant chemotherapy with a PD-L1 drug and a small single-arm phase 2 with 2 doses of immunotherapy. Now, when I look at those, I agree with you, Kate, actually. I think that the disease-free survival rates are way better with neoadjuvant immune therapy, but I also really struggle with the notion of defining a standard of care off a small single-arm phase 2. I think that's a real struggle.
Yeah. So what would, if that, as it is getting bigger and bigger with prospective collectively database, would that ever make you happy, or does everything have to be randomized?
I think you can define new standards without randomized data. I think you can, but the Council of Perfections always do the randomized phase 3 if you can. And that's what I would ideally like us to see, particularly when you're talking about curing patients as well. I think the other part where this is relevant too is that there's still 20-odd% of people who present with colon cancer who are obstructed, so will get an emergency operation, so you don't get to know their mismatch repair status until such time as their tumour is out. There will be discrepancies in terms of the biopsy versus the final histopathological specimen when you take it out and your mismatch repair has not actually been stained properly on your biopsy, so there'll be those. And there'll be places across the world where don't have routine access to pre-op IHC MMR staining, for example, or it just adds too much time to the staging paradigm. So I think that will be a group of people who we will find ourselves in that situation of, who we know have DMMR colon cancer, but only after the fact of the operation. And so I still think that is going to be a piece of the evidence puzzle that people will follow. Again, if I were designing it, I think, I'm a big fan of Georgina Long and the Nadina study, for example, which I thought was bold, and using 2 doses of immune therapy and then discontinuing adjuvant in those who had a great response. I think that's a beautiful model. But also she did compare in her study that to a year of the adjuvant, so did compare it to the standard.
Yeah, and I think where this sits for me is in the surprise stage.
Yeah,
3.
surprise DMORs, yeah.
Yeah.
So interesting debate. The other issue is whether, in fact, the randomized phase 3 trial, Chris, is actually neoadjuvant versus perioperative, so some doses after. But then the Nadina would be an argument against that maybe you don't need to do it in people who've shown have had a good response in these highly responsive tumours. But interesting, but I tend to agree with Kate. I think it would be struggle to randomise people to that trial because they'd all want to have the upfront treatment.
What about regulators, Craig? Do you think regulators will approve preoperative Ipi-Nivo on the basis of a single-arm phase 2?
115 patients. I just looked it up while you were talking. Yeah, well, I think they would struggle with that.
The other wrinkle is that the neoadjuvant Ipi-Nivo trials across disease types are investigator initiated, which regulators don't necessarily like either. So it's interesting where our souls are going is quite different from where regulators are going. But we'll see. As far as I'm aware, Nadina is not an approved regimen anywhere either. So,
well, it is. We're going to get to that later in the PBS update.
Oh,
so we're going to blow my trumpet. It's a study published in the Nature Medicine group. This is a study called Gasirasib, a KRAS G12C inhibitor, with or without cetuximab, an EGFR antibody, in colorectal cancer cohorts of a phase 2 trial in advanced solid tumours with KRAS 12C mutation. I was a co-author on this study after recruiting patients at our centre and having some input into the analysis and paper writing. But it was this drug, Gasirasib, or D1153, has previously been shown to, in phase 2 studies in lung cancer, with patients with tumours with 12C mutations, shown to be a very interesting drug that's gone into now phase 3 studies. So this was in cohort of patients with colorectal cancer with the 12C mutation. So there was a cohort that received the Gasirasib alone or a combination with cetuximab. So in the single agent arm, the overall response rate was 19%, disease control rate 92%, progression-free survival 5 months, median overall survival was 13 months. And these are in patients that all received oxaliplatin, irinotecan, and majority of them had previous VEGF inhibitor as well. And then in the combination cohort, the overall response rate was 45%, disease control rate 92%, median progression-free survival 7.5 months, and median overall survival not reached. So the company developing this in China is now moving this into later phase studies. And one of the features of this drug, it's a highly potent and selective inhibitor of KRAS G12C. The toxicity profile seems to be more favorable than some of the other drugs in development, with mostly asymptomatic abnormalities in the liver function tests was the most frequent toxicity. So interesting drug. And it's fantastic that there was multiple centres in Australia, but it's fantastic that some regional sites were also able to recruit patients to this study.
It's a pretty small group, isn't it, Craig? You know, the KRAS G12Cs, unfortunately.
In colorectal cancer, how many percent are they?
About 4 or 5, isn't it?
But it's such a common cancer, Chris. It's not that dissimilar to the DDMR pool that you were just waxing lyrical about for about 20 minutes.
Yeah, that's true. I mean, we've been 15% in the stage 2 and stage 3, so a much bigger population there. Again, we had a WhatsApp chat around the Motu the other day about a KRAS G12C for sotorasib or adagrasib, for example, panitumumab or stuximab in that patient population. And our colleagues hadn't had a suitable patient in the recent times, so a relatively small niche there.
Well, that's one of our problems in clinical trial domain, isn't it? That we're going to need to have lots of niche studies open to really bring new molecules to these patients. And we really need to change some of our paradigms about how we open studies and cost of opening studies.
Yeah, I think that's right, Craig. And that's really why your teletrials model is just so good, where you can have those leading from that centre A, because if we would get maybe 50 metastatic colons a year in our centre, and you're talking about 3 or 4%, like 2 a year, and then they've got comorbidities or something like that, and you can't treat them, eh?
Did you see what paper I was going to cover next then? That was a nice segue into teletrials. This is from JC Oncology, Impact of COVID-19 Pandemic Mitigation Strategies on Cancer Treatment Trials, a meta-analysis of industry and National Cancer Institute studies. So this is basically joint ASCO and Friends of Cancer Research Task Force. They invited industry and NCI sponsors to contribute to looking at quality of data during the COVID lockdown and whether there was any effect on the quality of data, with the pivot to doing online consultations, electronic consent, data collection, etc. And basically they found no, despite there was an initial decline in recruitment and then a recovery, and during that period they found no disruption to the quality of data. And so they just spoke about the need for sponsors and regulators to consider broader adaptation of trial flexibilities moving forward. So it's really, some concern about if there's a trade-off between quality and safety and doing things remotely. And this paper would argue about that. They analysed 67 trials with 12,000 participants in the US.
Yeah, I mean, again, we're really grateful for you being such a pioneer of that model, Craig, and showing us all how it's done and how it's done well.
That's nice. Thanks,
Is that
Chris.
the first nice thing I've said to you on this entire podcast in the 2 years we've worked together?
Maybe. Well, I'm going to blow my own trumpet again as well. Just another quick bite. The nivolumab and ipilimumab combination treatment in advanced ovarian and endometrial clear cell cancers. This came out of the MOST Circuit study, which is a study done across multiple centres in Australia and enabled recruitment in regional sites in Victoria through our Australian government, state government funding of our regional trials network and the Revitalise MRFF enabled grant. And so this is a group of rare cancer patients. Clear cell gynae cancers are traditionally considered to be aggressive and have low responses to chemotherapy. And so this was a broad number of rare cancers were recruited to this study. And this is the analysis of the clear cell ovarian and clear cell endometrial patients that received low-dose IPI and Nivo for up to 2 years. And there was only 28 patients. Medium duration response has not been reached in this group. 6-month progression-free survival, 58% overall survival not been reached. You had expected toxicity that you'd see, with ipi-nivo. So the overall response rate was 54%, complete response of 42%. There was an accompanying editorial by Ben Markman and colleague, and they again said this was really pointing the way forward for this rare gynecological cancer with low response rates to existing treatment, and needs more studies in this area, but pointing the way forward that immunotherapy for this previously treatment-resistant group of patients was required.
Yeah, look, I'm excited by you doing a gynae study for a start, so that's a good call. But I'm also excited by a something positive in clear cell gynecological malignancies because they're evil and people do badly, and often they are present in very young patients. So it's nice to have some hope in that. And again, very exciting that you have access to sexy things like most, which are a little bit trickier for those of us on the other side of the straight to access.
Yeah, it was we did a couple of most of these great studies because we're able to recruit, across a large number of sites, but contributing patients with rare cancers that really had no other, standard of care accessible treatment or trials. And so, this is, led out of Omiko and Oliver Klein at Olivia Newton-John Cancer Centre and in Melbourne, and a great model for how we need to collaborate nationally and internationally in these rare cancers to try and find better treatments. And lastly, I've got a couple of PBS updates. So Chris mentioned earlier the NADINA study, and in fact the PBAC in Australia altered its wording to enable investigators to utilise the NADINA protocol. So that's good news. You have immunotherapy for melanoma over the ditch, I assume.
What's immunotherapy? No, we do. In fact, our regulator has allowed us to use the SWOG regime, which is 3 pembros before, followed by the rest after in stage 3 melanoma, despite that not being a licensed indication. It's a funded indication rather than be a licensed indication.
Oh, that's good.
And there's a clinician-initiated submission at the moment with Pharmac for the NADINA protocol as well, even though IPI is not licensed in that indication either. And our funder is looking at the application as we speak.
Fantastic.
Well, maybe not right as we speak, but definitely this week.
Yeah, that's good. And a couple of other things that have changed. So nivolumab was being added for unresectable metastatic urothelial carcinoma in combination with cisplatin gemcitabine for cisplatin-eligible patient. Ivosidenib has been added for the treatment of patients with locally advanced metastatic bile duct cancer with the IDH1 R132 genetic variant, and concurrent with that, a new MBS item number introduced for the pathology test to detect for the IDH1. So that's pretty interesting.
Next time I might make you tell me what the ESMO scores for all of these agents are when you listen to PBS updates, Craig.
Yeah, sure. That'd be good. Also, alectinib, adjuvant treatment of ALK-positive non-small cell lung cancer. A drug called repotrectinib for ROS1 positive non-small cell lung cancer, which is interesting. And then, Kate, I'm going to get you to help me out. But they also listed ribociclib, which is interesting. Originally, the TGA, which is the first step, was licensed for the same populations as in the Natalie trial. So patients for use in combination with an aromatase inhibitor for adjuvant treatment of patients with HER2-positive, HER2-negative stage 2 and 3 early breast cancer at high risk of recurrent. But then for the PBS listing, they actually restricted it, defined the high risk recurrence to meeting any one of the following: cancer cells in at least 4 positive axillary nodes, or 1 to 3 nodes with a tumour size of 5 centimetres or grade 3 histology. Interesting.
Not surprising in that it is 3 years of ribociclib at God knows what cost to get a DFS benefit, absolute DFS benefit of 2.5% in that broader population. So if I was the PBS, I would have narrowed the population too. That's so I think that was pragmatic.
Yeah, good. And I just noted too the NCCN updated its guidelines to recommend ribociclib in these high-risk node-negative, hormone receptor positive, HER2 negative patients. There you are. So breast cancer continues to move along and seems to be differentiating into different tumours.
Oh, goodness. I think the New Zealand audience can wake up again now, Craig, after that very long interlude of currently unfunded drugs in New Zealand.
Sure. Well, all 5.
My mum listens 4 times. Surely that must make it 9. I'm going to sneak in a wee moment there just because I didn't want to finish on a breast cancer note. That'd be terrible. Now, everyone get out your ESCO bingo cards for all of the buzzwords from an abstract. This is a quick bite from Lancet Oncology. And I picked it out because it's got a really cool name. This is zanidatamab. I'm not even sure if I'm saying that right, but if I'm not saying it right, it should be its name. Zanidatamab. Plus chemo as first-line treatment for patients with HER2-positive advanced gastroesophageal adenocarcinoma. Prelim results of a multi-center single-arm phase 2 study. So zanidatamab, I'm going to say that as many times as I can in this quick bite, as a HER2 bispecific antibody in GOG adenocarcinoma. Part 1 was IHC 2+ and 3+, and Part 2 was restricted to IHC 2+ with FISH. And it looked at zanidatamab with standard fluoropyrimidine, platinum backbone, be it oxaliplatin or cisplatin. Part 1, safety tolerability. Part 2, overall response rate and the evaluable subset, which overestimates the response rate generally. They recruited a sum total of 46 patients. 46 patients. It's not that many for a HER2 population. Anyway, 85% male, so again, a little bit higher than the general population. Confirmed overall response rate of 76.2%. Man, that's high, 76.2%, with a median PFS of 12.5 months, median overall survival of 36.5 months, with the survival curve scaling the median there, and a clinical benefit rate of 78%, and toxicity was manageable. So zanidatamab, I'm sure, will go on to a phase 3 where they compare zanidatamab with chemotherapy to chemotherapy without zanidatamab. Right, how many zanidatamabs did I get into that segment? Was it enough?
It gets better. Zanidatamab is made by Jazz Pharmaceuticals. It feels like someone's taking the piss.
So I'm a bit speechless, but which tumours, Chris, are HER2 positive, but
Gastroesophageal adenocarcinoma.
it seems to have a particular role in biliary tract, is that right? Or there was a preponderance of biliary tract?
You know, it's pretty important in GOJ where it represents about 30% of the group, right? And then you've got the Claudin 18.2 population too. So actually, GOJ cancer is streaking ahead of colorectal in terms of its molecular subtyping already.
Anyway, it's exciting. There's all these new drugs.
Isn't it zany, all the data that's out there?
All right, fantastic. Thank you. I hope you're not too cold over the ditch. It's been pretty cold winter over here, but we're surviving. It's nice to see a bit of rain in some of the parched areas of Australia. So thanks for listening, sending your feedback. We're always happy to respond and include papers that you suggest. Anyway, thank you, Rachel, who's in heatwave conditions in Europe.
Always a pleasure. Thank you.
Thank you, Dr. Clarke.
Thank you, professors.
Thank you, Professor Jackson.
You're most welcome. I'm very pleased to keep our listeners warm with the latest hot data, or the latest data hot off the press.
Arc. It's a dad joke if you ever heard it. All right. See you next time. Bye.
Kia ora. Nā te wā.
Thank you for tuning in to the Oncology Journal Club podcast, proudly brought to you by the Oncology Podcast, part of the Oncology Network. For healthcare professionals seeking regular news updates and insightful discussions, we invite you to join our community at oncologynetwork.com.au. Your free registration includes a complimentary subscription to our weekly publication, the Oncology Newsletter, a valuable resource to stay updated on the latest advancements in the field. We value your input and welcome your feedback and paper recommendations via our social media channels, email and website. Your insights help shape the conversation and drive the direction of future episodes. This is Rachel Babin signing off for the Oncology Journal Club podcast.